me share from her. Can you see it, Flavia?
Yes, that's perfect.
Okay, once you want me to start, I go on.
The floor is yours.
Can I start?
Yes.
Okay, thank you, and greetings to everybody. Good morning to those that are in the morning, afternoon, and evening, wherever we are. I'm presenting care at birth as a component of strengthening newborn care in the program regarding implementation research to scale up and evaluate ACS, which is a multi-country project. And I'm here representing ACS Implementation Research and Sick and Small Newborn Care Group, Nigeria. This presentation will be focused on 3 aspects. The first aspect will be on PowerPoint presentation, lasting approximately 30 minutes. We will have opportunity to watch 2 videos and answer a few questions, also lasting about 25 minutes for us to be able to have an interactive session. Then it's expected that we will have extra 2 to 3 minutes, maximum 5 minutes to close up. So in the aspects of care at birth, there is a need for preparation. And ideally, preparation for care at birth should ideally start before every delivery. And usually, it is encouraged that the obstetrics and the neonatal unit will collaborate in this aspect. In preparing, one will want to have an idea of the risk factors present. This is to anticipate risk of complications, need for resuscitation, etc., particularly common situations like prematurity, asphyxia, and risk of infection. It's also very critical for us to be able to check equipment and to have it available, particularly those that are needed for basic newborn care. And also there is a need to anticipate the need of help. But most importantly, for all deliveries, a provider that is trained in neonatal resuscitation must be available solely for the neonate. In preparing, we want to look at common high-risk problems in our environment, particularly in looking into preterm birth, less than 37 weeks, meconium staining of the amniotic fluid, fetal distress, prolonged obstructed labor, multiple pregnancy, etc. All these are needed, and the list is inexhaustible. But these are just listed to show us common ones. When you want to prepare for birth, you need to ask basic questions. These are at least 4 major questions that should be answered. One will be interested in checking the gestational age at delivery, finding out if the amniotic fluid is clear or not, how many babies are expected to be delivered, and then what are the additional risk factors. And we should not forget that the labor room needs to be well lit and kept warm. The windows may need to be closed, the air conditions may need to be switched off. Then infection prevention is also standard. Standard hand washing techniques to be encouraged, and other standard precautions should also be practiced. At this particular time, the equipment needed for resuscitation and general care should be assembled, and the teams involved in delivery should be identified, and each role should be assigned for the individual, the one for the mother, the one for the baby, and the one for help in case it is needed. In doing all this, there should be effective communication among all the members, also with the caregivers. The basic things that are needed for newborn care is composed in this chart that I'm showing here. Basically, we know that the care at birth should be targeted at basic aspects. We want to make sure that the things that we are supposed to do in the first 1 minute is done in the first 1 hour, and then subsequently 1 hour, 30 minutes, and then other hours within the first 24 hours and thereafter. But my focus will be on the immediate care at birth and soon after birth. In other aspects of the seminar, other needs will be met. But let's briefly look at this chart. We know that it is encouraged that at birth, we want to ensure that the baby is kept warm and the baby breathes normally. Subsequently, we want to also ensure that at least in the first 1 hour, the baby is kept skin to skin. And then we also go ahead to limit, to prevent and to reduce the risk of infections. And this is actually based on the national protocol. But commonly, we talk about preventing eye infection, preventing a cord infection, and to also ensure that the baby does not bleed. I will go into that later. In this care at birth, it is best to recognize the potential complication of the baby. These color codes are needed for easy identification, easy and prompt actions that can quickly resolve problems in these babies. Generally, in neonatal chart, green means normal baby.
Ma'am, maybe
Aede,
you are
you're
muted.
muted. Sorry, Aede, you muted for a while.
No voice coming.
That's good. Not
Yeah,
yet.
somebody
Now it's
must
good.
have mistakenly muted me. So please, let's try and be careful.
Please go ahead, Aede. I think we just don't have your presentation anymore.
Is it showing now?
Yes,
Is the
your voice
presentation
is coming.
showing?
You are hard.
Is my presentation showing?
Yes.
Okay, thank you. So, like I said earlier, let's go to basic care at birth. The baby is breathing, is crying, and is vigorous. This is a normal baby. For such baby, we need to dry and keep warm and keep baby skin to the mother. We also need to check breathing and then try and estimate. Once we said breathing is normal, that type of baby should be kept on the mother's abdomen and also have access to the mother's chest for early initiation of breastfeeding. Then we go ahead and cut the cord, but this cord should not be cut less than 1 minute and usually not more than 3 minutes. Most authors will promote 1 to 3 minutes. Then we place the baby on skin to skin care as soon as possible, and this should be for minimum of the first 1 hour and may continue based on the weight of the baby. We will discuss that later. All babies should also have vitamin K at birth, 1 milligram for babies that are preterm weighing 1.5 kg and below. Those ones, 1.5 kg and above, those ones weighing below 1.5 kg should have 0.5 milligram. In countries where they practice eye prophylaxis, erythromycin eye ointment is usually prescribed, and those countries that have specific protocol for cord care, like in Nigeria, the use of chlorhexidine is promoted. Most importantly also, there should be continuous promotion of breastfeeding. When these babies are preterm, there are peculiarities, particularly when they are less than 32 weeks. So let's look at these peculiarities in these babies. Such babies should commence KMC immediately, to also have CPAP right at the time of birth, even if there are no respiratory signs. Caffeine should also be commenced immediately at birth. This is the current recommendation by the WHO guideline. We should promote feeding as much as possible and only give intravenous fluid as medically indicated. There should be monitoring and prevention of infections. Very, 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 very critical. And we should encourage early starting of KMC as much as possible, because this is also the current recommendation. When a baby has abnormal temperature, what do we do? Of course, we measure the temperature. If it is hypothermia, we need to improve our thermal care. And the most currently recommended method that is easy to practice and with great evidence is to continue skin to skin care. So such babies at the same time should be covered up, like in this baby, covered up with a cap and also well covered with a shawl. This skin to skin should be prolonged, particularly if the babies are less than 2,000 grams, or we are finding it difficult to quickly maintain normal temperature. If hypothermia is being prolonged or persistent, then we should encourage skin to skin for these babies. And this can be done through the help of the helper to the mother or a health worker. And we should ensure that the mother's skin is for the baby to have the real skin to skin. The mother can now cover herself after the baby is already having access to the skin. And this is needed for cultural and religious purposes. Babies that are small may have problems in direct breastfeeding, particularly when they are less than 32 weeks. These babies may not be able to coordinate sucking and swallowing, so we need to help them. So we need to be able to express breast milk into a clean cup and then use this as an alternative feeding method. This can also be used to relieve breast engorgement when present. That method will be in such a way that the baby is the one controlling the volume that should be given. It is not for the health worker to pour directly into the mouth of the baby, but the cup should be put at the lips of the baby, and then the baby is allowed to suckle, just as is shown here. And remember that breast milk is actually promoted at all costs. Formula milk is only when it is medically indicated. There are other components that we generally promote, even when caring for babies at birth. We should always check for possible congenital anomalies. Babies that are apparently normal should also be monitored, because they can actually deteriorate. If they were in the green zone, like I shared earlier, they may actually move to yellow zone or even move to red zone. So there should be an ongoing monitoring. Some protocols also encourage immediate immunization, particularly at birth, even within 24 hours. But depending on our national policy, we should go ahead and implement. We should always educate mother on hygiene, feeding, and etc. Because currently family-centered care is also being promoted, and mothers play their own role in caring for these babies. When we are monitoring these babies, what are the things we check? Number one, we want to check for the temperature. Is it hypothermic or the temperature is high? And then we do the needful according to our protocol. Then we also check the breathing. Does the baby have respiratory problems? Is there apnea? Is there cessation of breathing? Or is there other evidence of respiratory distress? Is the baby grunting? Is there severe chest injury? Ideally, babies should also have their oxygen saturation monitored at least once per shift. This will allow us to assess the baby correctly. Also, in a standard neonatal unit and labor ward, there should be access to checking of blood glucose and also serum calcium at least. We should constantly check for signs of infection, even when there are risk factors or not, and their weight should be checked based on our protocol. Some believe that weight should be checked immediately after birth. In the national protocol for the country in Nigeria, we encourage weight to be checked around 1 hour of life. But we should practice whatever is our national protocol. Now let's go on to neonatal resuscitation and see how we should do it ideally. We know that there are no 100% specific factors that can predict the need for resuscitation. Therefore, all babies must be prepared for. So anticipation and preparation is actually the key to successful resuscitation. On a general note, it is estimated that 4 to 10% of term or late preterms may require positive pressure ventilation, and about 1 to 3 per thousand of babies may require major resuscitation involving chest compression, use of medications, etc. We should also take note that for newborn, the respiratory system is a critical issue in terms of resuscitation. So the airways, the breathing pattern, before we talk about cardiac, before we talk about drugs. There are two major algorithms for neonatal resuscitation, namely the helping baby breathe and the neonatal resuscitation training module. But we know that all health workers should have at least training in one of these, and every birth should be attended by at least one qualified person trained on helping baby breathe or neonatal resuscitation and should focus on the baby at the time of delivery. In planning for a delivery, we should assume that every baby may need resuscitation. We should prepare our equipment. Therefore, it is recommended that in the labor room, in the neonatal intensive care unit as well, we should have equipment checklists. The ones highlighted in red are compulsory. We should have our resuscitation flow chart on the wall. There must be a timer. They must have tapes and scissors. With regarding warmth, we should have 2 linen and a radiant warmer. Those ones in pink, this like the CPAP. If we are very blessed in our centers, the labor room should also have CPAP. Remember, we said all babies less than 32 weeks should have CPAP commenced from the delivery room. The ones in green are optional depending on the level of our facility. If we are level 2 plus or level 3, it is expected that those ones will also be present, particularly if we have the skill for endotracheal intubation. Remember, we also said all babies should have oxygen saturation assessed at least once per shift. So pulse oximeters and oxygen sources are compulsory. If we are using the neonatal resuscitation training module in our facility, that involves the use of drugs, and we must have access to umbilical catheterization and the skill needed. Adrenaline must also be present, usually diluted as itemized air. Other things that we will need will be normal saline, 10% dextrose, and of course, water for injection. This is a flow chart for the neonatal resuscitation training. There are subtle differences between helping baby breathe and this neonatal resuscitation training flow chart. But let me just mention maybe two critical ones. Let me mention two critical ones. For instance, for the neonatal resuscitation training module, is relatively more complex. It's not as straightforward as the helping baby breathe. So most trainings use the helping baby breathe. This neonatal resuscitation training module comprises of A, B, C, and D. That is very, very important for us to note. Meanwhile, the helping baby breathe does not contain use of drugs. Also, for this neonatal resuscitation training, it is expected that we will also continuously monitor the oxygen saturation. That is also not compulsory for helping baby breathe. In this presentation, I will prefer to go through a little bit, 1 to 2 minutes, on helping baby breathe. In this aspect is a very simple algorithm that promotes simple methods and use of arrows and color coding. Very simple. The green color, like we said earlier, connotes healthy, normal baby. The yellow color means mild to moderate problems, while the pink, and with a varying intensity of color, connotes severe condition or emergency condition that needs urgent attention. All babies that are delivered should be dried thoroughly with having 2 towels. The first towel is removed and the second towel is used to cover the baby to keep the baby warm. So when these babies are delivered, we ask simple question. Is the baby crying? If the answer is yes, just dry thoroughly and then keep baby mother's chest and keep baby warm while you keep examining for respiration, and then cut the cord and leave the baby skin on skin to skin care. This will be what we will do for 9 out of 10 babies. 1 to 10% of our babies may fall into yellow zone, while 1 portion of this 10 may fall to the red or pink zone. But let's look at a baby that is not crying. Such a baby will still continue to keep warm, we clear the airway, and then we stimulate breathing. At times they may respond, and then you transfer the baby to the green zone. But some of them may still not respond, and you want to start ventilating. Remember that this keeping warm, this dry thoroughly, and stimulating, as well as commencing ventilation, should start within the first 1 minute that we call the golden minute. No baby should have problem with breathing and be left till after 1 minute, particularly those of us that are so much interested in taking Afghan. Please, let's ensure the baby has access to positive pressure ventilation within the golden minute. If that baby does not respond, then it falls into the red zone or the pink zone. And in this case, you will not be able to do it alone. You have to call for help. You try and check your ambu bag and be sure it's still okay, and then you reapply greater pressure and reposition the neck, and you continue to ventilate. In instances where babies don't respond, then such babies should be transferred to higher centers if we don't have capable special care baby unit. But if our special care baby unit is established, such babies should be admitted and then monitored. We should remember that these babies that are being ventilated should have the efficacy of our activity when monitored. Let me just say a few things about this slide. Remember that we should do suctioning and before we if we have secretions. And look at this hand. This particular baby has this procedure must show total seal covering mouth and nose with our hand in the C and E, in a form of C and E shape, and then ensure that the neck is just in the sniffing position, not hyperextended, neither is it flexed. And we continue to check the color. Once it is properly done, there should be a drastic change in color from this pale skin to a pink skin. And this is very, very important. We will see more of this in the video that we are going to show us. This is demonstrating the procedure I said. Make sure you open the mouth, neck is well positioned, and then start from the lower part of the lip to the nose, and then put a small pressure here. Remember also that squeezing should also be controlled. We don't want total squeezing. Squeezing should be commensurate to the weight of the baby. So when we have babies that are not responding, we go ahead and count the heart rate. There are two ways of counting the heart rate. Ideally, we should have our stethoscope, so we count for 6 seconds and multiply. But if the stethoscope is not available, then we can use the cord also. But the best is the use of the stethoscope. And in this case, remember we said by now we should call for help once we get to this part of need for chest compression. When we resuscitate successfully, it is not to forget the babies. We should refer to a special care baby unit. And most babies may still need respiratory support, particularly the preterm babies. They may need CPAP. So we continue to monitor these babies. We also need to check and prevent hypoglycemia, hypothermia. And remember, these babies should also have their oxygen titrated, because we know that oxygen is also toxic when it is above normal levels. It is recommended that newborns should not saturate at 100%, and we should discourage 100% of use of 100% oxygen as much as possible, and we do not encourage 100% SpO2, particularly when they are on oxygen. For these preterms, there are some basic things that we want us to consider. Remember that these preterm babies tend to have higher risk of complications, and these should be sorted out and looked for, and then investigated and managed. The ankle bags we use in them are also of smaller size. Usually we use size 0, and squeezing ideally should be 1/3 to 2/3. Hardly do we do total squeezing for these babies because of risk of pneumothorax, and we should plan for use of CPAP in them, and of course IV NICU admission, like I previously mentioned. And then they also need appropriate fluid. They have large body surface area with respect to their weight, so they are very prone to heat loss. So we should give fluid as needed according to our protocols, and we should do some investigations to check for metabolic complications. If there is a need for prolonged hospital stay, please let's be strict about infection control, and we should promote family-centered care. All babies after proper resuscitation, after they are with the mother and everything, they should have continuous monitoring. What are the things that we check? We check for danger signs that's found through major systems, the respiratory, the cardiovascular, and the neurologic. We also assess the temperature, we assess feeding, and we assess for metabolic problems, like I earlier said. So this diagram shows common danger signs. This baby is so weak, is not feeding well. This baby has hypothermia, is very cold, or the temperature can also be high, higher than 37.5. Baby may have lower chest wall indrawing or intercostal recession. The chest indrawing may be mild in a normal baby, but once it is severe and it is constant at every breath, then we say the baby has severe chest indrawing. Baby may not even move at all, or may move only on stimulation, or the baby may be convulsing. These are very common danger signs that connote great morbidity and high potential of mortality. They should be assessed in every baby. When we are breastfeeding this baby, we should also make every attempt to ensure that breastfeeding becomes successful. What are the things we need to do? We need to support breastfeeding. We need to ensure there is good lactation and attachment. We need to ensure that lactation is promoted in the mother. We check for possible problems in the mother. Is there breast engorgement? Is there breast abscess or mastitis? And this should be properly sorted out according to our protocol. The equipment at the delivery room is also critical for us as neonatal nurses, neonatal doctors working in labor ward and SCBU. We need to ensure that the equipment are maintained, they are properly cleaned, and they are stored in a place that is accessible, that is also clean. And we want to make sure that periodically we check that they are available. We may need to occasionally deassemble and reassemble and check their effectiveness even before a delivery is planned. This should be routine per shift in an ideal setting. Now, what have we been saying in terms of general care at birth? We are saying that we should promote skin-to-skin care at birth. We should give the best to maintain normal temperature. We should promote KMC for preterm babies, particularly those ones that are very preterm. We should make sure that we prevent a baby from becoming cold or becoming hot. And what are the things that we do based on our national protocol? I use Nigeria as an example. We promote skin-to-skin care 1 hour of birth, and then IKMC as indicated, and prolonged skin-to-skin care also as indicated. We also promote prophylactic eye ointment to prevent eye infection, and then we use chlorhexidine gel to prevent cord infection. In Nigeria, we practice weighing within around about 1 hour of life, but based on our own national protocol, we should follow, because some also promote immediate weight, and that is also with evidence. All babies should have assessment of respiratory signs, cardiac signs, and neurologic signs, and as well as general signs, so that we can classify the baby either be in the yellow zone, the green zone, or in the red zone. And those ones in the red zone suggest critical issues. When we work in some centers that are level 2+ or more, we have opportunities to do other aspects of care, particularly post-resuscitation. If you work in those centers, this slide is available for you to read after, because this may not be available in most of our level 2 facilities. I'm not going to spend so much time in this aspect. So thank you. And then we go ahead and do discussion after. And I'm available for questions and answers. But we will go now for video, and then we have our questions for us to round up. And then any other interaction will follow. Thank you.
Thank you, Aede. Thank you very much. So I will share the videos now. And for the people who are in the audience, you can start raising your hands if you have questions, so we will be able to treat the questions and comments after the videos. So I will start sharing.
Before the baby is born, warm the baby.
Are you ready? Yeah. Can you see my screen?
Yes.
Yes, Flavia, we can see well.
Yeah.
Before
Can you
the
hear?
baby is born, warm
Yes,
the baby.
we can
Yes,
hear.
yes.
Keep it free from draft.
Okay, so I will start from the beginning again. Okay, let's go.
Before the baby is born, warm the birthplace and keep it free from drafts. It should be at least 25 degrees. Before the baby is born, warm the birthplace and keep it free from drafts. It should be at least 25 degrees. Then change the wet cloth for a dry one and cover the baby, leaving her on the mother's warm abdomen. Keeping the newborn skin to skin with the mother is the best way for her to stay warm after birth. The mother is exactly the right body temperature for the baby. Use a warm, dry cloth to cover them both. A bath can make the newborn dangerously cold. Wait at least a day. Wait longer if the baby is sick, very small, or the environment is cold. Then change the wet cloth for a dry one.
Sorry.
Cup a bath. Teach the mother to check the temperature of her baby's feet. If the feet are cold to the touch, the best way to warm the baby is with skin-to-skin contact on the mother. Teach the mother to check the temperature of her baby's feet. If the feet are cold to the touch, the best way to warm the baby is with skin-to-skin contact on the mother.
Okay. So there is the second video with more details, but I also have the questions. Would you like to go through the next video?
For 10 minutes.
Disagree that.
That's it, exactly, I agree. So maybe we should go through the questions. If there are people in the audience who would like to ask already questions to Dr. Aede concerning the presentation, comments, raise your hand. There was a hand that was raised before, but I cannot see it anymore. Yes, Osama?
Thank you, Flavia. My question is, what is the ideal room temperature at the birthplace?
I did not understand. Could you repeat, please?
What is the ideal room temperature at the birthplace?
Ideal room temperature.
Yes.
Yes. Okay. Aede, would you like to answer that, or you want me?
Yes, I would say that it is encouraged that the room temperature at the delivery room should not be less than 25 degrees Celsius. But so that means that if your delivery rooms have AC on, air conditions on, at the time the baby will be delivered, we should please switch off the air condition, because the air condition can give us as low as 16 degrees, and that is not encouraged for a newborn. It should not be less than 25 degrees Celsius normally.
Yes.
Does that
Thank
answer
you,
the question?
Thank you, Dr. Aede and Flavia.
Thank you, Aede. Can definitely agree to that. Very good question, especially concerning the OT. We have, okay, we have some more activity now. We have Dr. Sabir, I think.
Yeah, thank you. Thank you, Aede. The fantastic presentation, as always, Aede do. So I think if there is a slide that was saying about the skin to skin. So if I can recall, is it saying that less than 2000 on and do not breathe, then skin, something like that? I mean, the recommendation, even if it is 2.5, she should have a skin to skin immediately. That's kind of, so can I take a look of that slide again that is saying that skin to skin? What is the written there? I might have mistaken.
The slide on skin to skin, I can display it, Aede. Which
Yes, please go ahead.
Yeah, okay. So, Dr. Sabir, maybe you can help me navigate this. Which one?
Yes, that is on the action chart.
This one?
Above A6 Oh, sorry, yes, but go up, yeah. There is a written that who skin to skin for whom, something like that. There is a text on that, less than 2000 and or cannot maintain temperature, something like that. The text is there. Skin to
Here?
skin.
No, it's the next slide. The next slide.
The next one?
Yes. No, just go further down. Further down. That is the first one. Down. Let's go down. Yes, I think this is
yes.
the one.
Yes, this one. Yeah. When a baby cannot maintain normal temperature when wrapped or weight less than 2000 prolonged, or that is prolonged skin to skin. Okay. So that's okay, because the recommendation is all baby, even if it is less than 2.5, they should have immediate skin to skin. So thank you. Sorry, that's what I missed. Prolong the word that I cannot find that one. So thank you. Sorry, I find that.
Thank you for the question, Dr. Samir. So I'll just resume for everybody. The recommendation, we agree that skin to skin care at birth for all babies that are vigorous, and then prolonged skin to skin care for small babies, less than from 1.8 to 2.5 kilos, or prolong even more further for babies that cannot maintain the temperature or weight less than 2 kilos. Yes, we have Worku from Ethiopia, please. Worku, please go ahead. We cannot hear you. I don't know if you're talking or if there is a problem with the connection. Yeah, okay.
Do you hear now?
Yes.
Okay, I have one question. Why stimulation is necessary before checking is the presence of secretion?
The question is why stimulation is necessary?
Before checking the presence of secretion, because there may be aspiration during stimulation.
So the question is why we have to stimulate a baby that breathes. This is the question? Or
yeah.
The question is why to stimulate a baby that's breathing. Is it the question?
Yeah.
Yeah, okay. Aede, would you like to go ahead and answer that?
Yeah, I think I heard him correctly. His question was actually, why should we stimulate? Why should we stimulate why we have not checked for secretions? I think that is the question he's saying. That why do we stimulate? You carry a baby and the first thing you do is to dry thoroughly. I think his question is, why do you dry thoroughly first? I hope I'm right, because he said two different things. I just want to make sure I'm correct. Can he repeat his question, please? Did you hear me, Flavia?
Yes,
Yeah.
I can hear you. I am not sure, so
Yeah, if I may
could
come
you
in,
confirm?
I
His
think
question was
what
not
you
very
said,
clear.
I think you're right, Aede. Worku asked whether, if you stimulate before suctioning, there's chance of aspiration. So that is the question that is concerned about. Go ahead, Aede. You heard him right.
Okay, thank you. Thank you. For such babies, like we said when we were presenting, what we do actually depends on the category of the baby. So you want to find out, is the baby vigorous? Is the baby crying? If a baby is not crying and is not vigorous, you want to check, you want to still dry, because the baby has a lot of amniotic fluid and that can worsen the condition. You still want to start with drying the baby and then cover up with a better linen that is warm, and then you go ahead, suction the baby and probably ambu back. So in terms of the drying, the risk of not stimulating and not drying far outweigh the risk of probable aspiration. Previously, we used to talk about meconium, stain liquor and all that, but that evidence has shown that does not really affect prognosis and does not really have to be a decision in terms of what to do. But asking the question, is this baby breathing? Is this baby vigorous? Is this baby crying? So that once the baby is not crying, then you still go ahead and dry. All babies must be dry because you don't want them to be hypothermic and then develop all the complications of hypothermia that may likely kill the baby, even more than the risk of aspiration. So, but I said in the presentation as well, we should note that not all babies need suctioning, not all babies. Previously, we were suctioning all babies, but currently the promotion is that it is only babies that have excessive secretions in the mouth and are not breathing that you need to suction, or that are breathing abnormally. They have excessive secretions, they are not vigorous, they are breathing abnormally, you need to suction. So it is not suctioning before drying, before stimulation. Remember, stimulation comes with a drying. They are not two processes. It's the same process. As you are drying, you are also stimulating. So I don't want us to see it as a separate procedure. It is concurrent. And remember to remove the first linen and cover the baby with a second warm linen, because that is also very critical. I hope I've been able to answer your question. Thank you.
May I ask one question, Flavia?
Yes, who is
Asrat.
Asrat? Yes, please. You're the next hand. Yeah, go ahead.
Okay, thank you so much. Thank you for the presentation. I do have one question. In case of resuscitation, if the baby is not crying or if the baby is not breathing at all, is it not possible to do back mask ventilation before cutting the umbilical cord? If we do resuscitation while the cord is attached to the placenta, the baby may get additional oxygen and blood from the mother. And additionally, when we do ventilation, he gets also oxygen. So it's not in the current recommendation, but few people do resuscitation while the cord is attached and few are not doing. What is your suggestion regarding this issue? Thank you very much.
Okay, remember that we are currently promoting evidence-based clinical practice. If a baby needs resuscitation, you cannot predict how many minutes that baby will need. We cannot predict. And we do not recommend that you don't cut the cord above 3 minutes, because that could also affect the baby. May actually lead the baby to develop polycythemia, which is a set of problems on its own. Then secondly, a baby that needs resuscitation, you need to put that baby on a flat surface, because the baby may need positive pressure ventilation, may also need chest compression. You cannot do chest compression on the abdomen of the mother. So these are the reasons. Number one, we don't want extremely delayed cord clamping. Number two, we want to be able to have the baby on a flat surface, and the abdomen of the mother may not be suitable to give us that very flat surface. Number three, that we cannot determine how long we will be with the baby. So it is also very good for us to have a separate place for the baby where the baby will also have access to a radiant warmer. A radiant warmer is part of the equipment that should be in our resuscitating area, and it can be used when we are resuscitating the baby. But most importantly is the need for a flat surface, and the fact that we also don't want to promote polycythemia. So these are the main two reasons. Other reasons are additions.
Yes, thank you, Aede. Dr. Asrat, I am completely agree with Aede. I think this is definitely the good answer. I would just like to maybe add to that there are indeed some centers that have been doing that, but it's more in a research context. And they have completely a new structure that is created to do that. As Aede was saying, you need a flat surface, you need warm. So they created new devices actually to do that and to adapt into the delivery room, which are really complex and are not yet completely fully tested or proved to be effective. So it's more on the theoretical point of view. Maybe in the future, but for now we still don't. We're still not sure about that, and it can be dangerous to start doing in real world context.
Thank you very much. It's still under the study.
Yes.
Yeah.
So, do we have any more questions? Okay, that's good. So, well, we have maybe a few minutes more. We are actually completely finished with the time, but we had some questions. Maybe it's going to take 5 minutes, so we can go through them. Would you like to try that, Aede, or would you like just to do the final considerations?
No, let's go to the questions from your end. It won't take us more than 5 minutes.
Yeah. Okay, so you all know most of you know how it works with the QR code. So I'm going to share it with you. So you can flash the QR code. Oops. Work, I have still your hand on. Do you still have a question, or is it good? I don't have an answer. Okay, so you can just flash the QR code. Yes, I have one question meanwhile, so we can treat that. Tayyab, Tayyab. Sorry. You can go ahead with your question while people are connecting. No? Maybe it's a accidental hand. Okay. So let's see. You start connecting. We have a few connections already. Maybe 1 minute and we'll be able to start. So this is a competition, this one. So we will be able to choose a name. We have 30 seconds per question, so it's more about being fast. And we'll see the leader in the end. You don't have to use a real name, so you can use a pseudonym. Good. Okay, people are connecting. That's very good. Okay, let's go. So, okay, we have 15 players. That's good. You want to start, Aede? We can start? Or wait for 16 players. Let's start.
You can start from your end. I'm okay.
Yes. Oops, sorry. I was just in question one still.
So learning is probably set up.
Okay. That's your question. What will you do for a baby with mucus and secretions in the mouth and airway but breathing rapidly with tachypnea and irregularly? Dry and keep the baby with the mother, positive pressure ventilation or suction? Oh, good. So we have 4 people that gave the right answer. Do you want to comment, Aede?
Yes, we should just note that this baby has mucus secretions and both in the mouth and in the airway and has tachypnea. So the secretions need to be removed. So that's the answer.
Okay.
We need to clear the airway. Thank you.
Thank you. So that's it. So since we had a baby with tachypnea, that was clearing the airway solution. Let's go to the next one. Okay, you ready? Okay, let's go. Every birth should be assumed to need resuscitation. Yes or no? The question is more like we should be ready for resuscitation in every birth. Yes or no? Oh, we have 8 yes and 8 no. So the right answer was yes. Aede, do you want to comment?
Yes, we said that all babies should have should be prepared for, all births should be prepared for, including resuscitation. So, and we emphasize the fact that we cannot predict 100% which baby that we need resuscitation. So all babies should be prepared for.
Okay.
All deliveries have resuscitation area prepared.
That's it. Next question. Okay, let's go. One health worker trained on neonatal resuscitation is sufficient for all deliveries. Yes or no? So having one health worker trained in your facility is enough for all deliveries. Yes or no? Oh, that's good. Most of people answered no, which is the right answer.
This is the right answer.
Would you like to comment, Aede?
Yes, we also said in the presentation that ideally all the people involved in newborn care should be trained on resuscitation. And most importantly, we said in an ideal setting that the people attending to mother and baby at the delivery should also designate one trained worker that has received training on neonatal resuscitation or helping baby breathe specifically for the baby in an ideal setting. So one health worker is definitely not enough for all deliveries. So the answer is no.
Next question. So this one is different. You can just scroll. No is on the left and yes is on the right. A preterm delivered at gestational age of 30 weeks should be given the following immediately after birth: a bath, CPAP, immediate KMC, caffeine, and adrenaline. We have a few answers moving around. So this is a preterm baby that just was born, and he doesn't necessarily need resuscitation. It's just for any preterm delivery. What should we give to any preterm that's just born? Okay. So maybe you can go through that. Do you want to start going through that, Aede?
Yes, have they all answered? Okay. I think they are still answering. Maybe seconds more for them.
Yeah.
Yeah, it has stopped moving now. This is a preterm baby. Gestational age is 30 weeks. Remember, we said all preterms less than 32 weeks should have CPAP in labor room, should also be commenced on immediate KMC, and should have caffeine at the delivery. This is the current recommendation. We don't wait any longer till they develop signs. So, but we should not wait. We should not wait for any baby until after 24 hours. How much more a preterm baby? So this baby should not be bathed soon after birth. You know, the word is following, it's immediately after birth. You cannot bathe a baby that is 30 weeks and then you are pouring water, either hot water or cold water, it doesn't matter. You are exposing that baby to risk of hypothermia. So they need to be on skin to skin care and to be covered, not bathing. Bathing is discouraged. Then adrenaline should be given to babies that have problems with the cardiac activity. The heart rate is absent or it's extremely low. You can't count. That is not the routine practice for a preterm baby. So the correct answers will be CPAP, immediate KMC, and caffeine, but no to bathe and adrenaline. Thank you.
Thank you. So just added here the WHO recommendations that we have strong evidence of CPAP for respiratory distress syndrome in neonates, preterm neonates. CPAP immediately at birth that may be considered in all neonates with or without respiratory distress if it's available. And also caffeine, which is recommended for treating apnea for all preterm infants and before extubation. And also for for prevention, if you can do this for preterm babies. So this will come along for you to look into. So question 4, I think is the last one. So let's give it the most of it. Okay, let's go. Which activity should take place in the first minute after birth in a vigorous crying baby? Baby's crying, he's fine. What should we do? So we can answer multiple, we have multiple possibilities. I hope it worked. Yes, definitely. Dry throughoutly and skin to skin care are the activities that we were supposed to do for vigorous crying baby. And we have to do delayed cord clamping. So it's very good that you didn't check on that. And bag and mask ventilation only for babies that need it. Also suction only for babies that need it. And vitamin K can be done after doing this first, doesn't have to be done in the first minute. And this is your leaderboard. Let's see who is the champion. Amna Kalim, congratulations.
Thank you.
Thank you, congratulations.
Amna Kalim, congratulations.
That's good. Well, so this was the end of our SSNC seminar. Aede, would you like to do the final words?
I will do then, maybe somebody from WHO. I just want to appreciate the participants. They were actually very, very active. We had about 43 participants. That's very, very great across the various countries.
Thank you, Aede. That's true. Suman, I don't know if you'd like to say some words.
No, I'm just glad that our first webinar has been such a big success. Thanks, Aede, for a wonderful presentation, and thanks everyone for your interaction. We just do hope that these webinars will make a change in practice. And the main change in practice we are looking at in care at birth is delayed cord clamping, thermal care, and skin-to-skin contact at birth. Thank you, and back to you, Flavia.
Thank you. Thank you very much. So thank you everyone for your participation. The webinar will be available.
Thank you, Suman, and thank you, Miriam.
Thank you. I sent you the countries, the presentation, and the webinar recording will also be available. And hoping to see you on the next webinar in 2 weeks for the Bangladesh team that's going to be presenting respiratory distress, including CPAP. Thank you.
Thank you. Thank you so much. Bye.
Thank you, Flavia. Goodbye.
Thank you, Flavia.
Thank you.